Hello, everybody, and thank you for coming to the National Grand Rounds. This has been something that I have put together over the last several years. I'm Paul Musey from Indiana University, and this is Peter who is now going to be taking this over, and I'll let him introduce himself.
Thank you, everyone. I'm Peter Ho from the Brigham Women's Hospital, and it's a pleasure to follow in Paul's footsteps.
I think that we have two great dynamic speakers this afternoon who are going to really talk about the intersection of research in their careers and lives and the impact that they've had. And I think without further ado, we will introduce and we'll get started.
Yes, thank you. Yeah. It is my honor to introduce Dr. Marie-Carmelle Elie, who is an endowed professor and chair of the Department of Emergency Medicine at the University of Alabama, and recently inducted to the National Academy of Medicine. She obtained her undergrad degree at Columbia, medical degree from the State University of New York, Brooklyn, completed EM residency at Mount Sinai, went on to complete critical care and trauma fellowship at Shock Trauma Center, University of Maryland. She is triple boarded in emergency medicine, critical care, and hospice and palliative care medicine, and has previously served as faculty at the Rutgers University and University of Florida College of Medicine, where she has leadership roles. She's a clinical trialist and former research director who spearheaded the growth of a multi-million-dollar research portfolio. Dr. Elie will discuss strategizing for successful collaborative research in emergency medicine.
So thank you all for being here. I was just telling Dr. Aufderheide that now we can go home and tell people that we had standing room only and it was catered. So I really do appreciate all of you being here, especially those that are standing right now. I want to thank Dr. Ho and Dr. Musey for inviting us to speak today. And I was asked to really talk about my journey today. So this is really going to give you a sense of basically how I was able to navigate the research space in emergency medicine in order to build a research career as well as a research mission for my department. So no financial disclosures. I'll start with the first part of my journey, and it starts as becoming a faculty member at an unnamed institution. At this institution, I joined that department, actually a division of emergency medicine of the Department of Surgery, because the chief was going to be my research mentor. And so I was really excited. He had a great broad epidemiologic background in research, particularly in the areas of stroke, in cardiovascular disease. And I'll tell you very quickly that, within 6 months of joining the faculty, he resigned. And so I had to find a next mentor, right? Because it's really important. They always tell you, if you're going to do research, you need to find a good mentor. And so the next mentor that I identified, because I was working in the medical ICU, was the chair of medicine. Well, within a year of him becoming my mentor, he was walked off campus in handcuffs. And 2 years later, my MICU director, who decided to take me under his wing, teach me a lot about writing, helped me to build my repertoire in writing, manuscripts, but ultimately get seed funding for my first pilot studies, then also left. So there was ostensibly a mass exodus, and so then I left. And so I went to my next institution, and I specifically intentionally looked for an institution that had resources and a pretty strong research enterprise, but also a collaborative environment where they'd be willing to work with an emergency physician. And there were plenty of people there that were willing to take me under their wing and work with me as an emergency physician. But this is what I found when I first got to that department. These were the local metrics in my department when I got there, right? So some of the other research that I hadn't done. So the number of ED faculty awarded independent investigator funding, 0. The number of clinical trials ever conducted in that department, 0. The number of grants that the EM research chief that was there had ever written, 0. Amount of funding in the department for research, that's the number up there. The number of IRB full board proposals that were approved, 0. Right? So how was I going to be able to launch my career in clinical trials research in this environment? There were no research staff. There were two research mentors that were in the department that had had some funding in the past, and one of them was going to be retiring the next few years. But again, there were very few resources there. And so the question is how do I, overcome the challenges, right, that I've now encountered as somebody who really wanted to foster a career in research in a department that didn't have very many resources. So no infrastructure, no funding, very little mentorship, and actually, we didn't have any credibility. So the first thing I sought out to do was identify sponsors in my institution. I went first to my chair, and I said, this is really important. If I'm going to be able to do, hey Phyllis, if we're going to be in a position to do this kind of work, we really need to make sure that there's funding, not only for me, but other researchers that want to do this work. So can you help me cost share my effort? So I had to negotiate before I submitted my NIH grant that my chair would be willing to cost share my effort, because it's basically, there's no budget for that, right? So I had to budget that in advance before submitting the grant that I thought was going to make everybody really happy, right? So, and he did. And he promised that if I got the grant that he'd invest in my cost share. I needed, upfront some time to be invested in so that I can actually generate the kind of research that would ultimately get me funding and protect my time. I then went to the CTSA. And I said, look, we have no resources. How can you help? And so the CTSA actually provided me with a voucher and sent to our department a research coordinator that had approximately 25 years of experience. She had a ton of regulatory experience, and boy, did she whip us into shape. And so she created this infrastructure for us so that not only we can get our studies through the IRB, but would be audit-proof when the IRB would show up, right? And so so we got that coordinator, and that coordinator not only helped us create the infrastructure for our regulatory advancement in the department, but also helped to train those individuals that perhaps wanted to work in research and be a coordinator or a research associate. And then finally, I had to run around campus, basically petitioning other funded faculty to share and ask whether or not they'd be willing to let me use their lab, use their resources, share some of their research staff, perhaps even throw me on a couple of their supplemental funding awards and see whether or not, there's some collaborative outcomes that or collaborative work that we can do together in order to meet mutual needs in both departments. And that's how we started. And so with that, we built a little bit of infrastructure. And then the next step was really creating an EM-centric mission. And we did that by building a team. In our minds, besides having the regulatory coordinator come in from the CTSA, we really felt it was important for us to have a grant specialist in our department. So that was our first step. And that grant specialist actually helped us to get our first two funded grants into the department within 1 year. After that, we were able to bring in more coordinators that were trained, then research associates, and ultimately, when we started generating an environment and a reputation in the department and in the institution, we actually had students that would come to us and ask to volunteer in our environment. And this happened over the course of 4 years. So in the terms of the EM-centric training and onboarding, one of the things we really wanted to make sure is that our team really understood that practicing or conducting research in our environment was actually different. The CTSA was very confused as to which coordinator to consent to us because, for the most part, they were doing a lot of outpatient work, and it was mostly oncology work. And so working in an emergency department was very new to them. And so we had to have every single staff member on board by doing a rotation with one of our faculty. We had rigorous regulatory and ethics training performed, especially because we had so many vulnerable patients with lack of decision-making capacity in our environment that and we needed to come up with a pathway for consenting them for research. We created a simulated patient interaction platform so we can train every person that came into our department so they can learn how to interact specifically with emergency department patients that might be vulnerable. It may have lower decision-making capacity to consent for research. And then we had monthly operations and quality improvement meetings around our research. We also created a scientific review committee that was specifically designed to engage faculty and give them an opportunity to listen to research that was being conducted. And over time, this created a forum, and there were more researchers and more faculty that wanted to be part of what we were building, right? So that infrastructure in that committee structure gave people a forum to not only talk about their research, but also allowed them to bring in their research questions in a very safe space where they could ultimately get some of their science conducted. And so this also provided us with an opportunity to provide critical appraisal in a safe space before the IRB to research. We invited them for faculty presentations, and there were mock presentations also in that setting for national meetings. So this is what we look like over time. Our research staff actually increased pretty precipitously over time. The more infrastructure that we created, the more staff we were able to hire. So after approximately 5 years, we had a little over 45 staff in our department, all working under the research mission at my institution, at my prior institution at University of Florida. And this allowed us to recruit thousands of patients every single year. This is what our research associate program looked like. So the vast majority of them were either in the department for 1 or 2 years. We cut most people off at 2 years. And by that period of time, those research associates would go on to, the vast majority of them, well, actually over 80% of them, would go on to apply and pursue higher degrees in medicine, public health, and other health professions. We also established a medical student research program, which was a huge success. So in their first years, medical students were engaged to spend the summer with us, and we would get them to complete some preliminary work over the summer, but ultimately, these same students would be engaged in going to regional meetings and ultimately national meetings, and were engaged in longitudinal involvement or research in our department over several years. Many of those students would ultimately become emergency physicians, and I think this is a great opportunity for most academic departments to not only engage students, but also get them to aspire to be us, right? A reason why a lot of our colleagues are doing really well with longitudinal engagement with students is because they are engaging them in their first or second years in research, and this was a great success in our program. So, building bridges. Local credibility was very low when I first got to that institution. So I'll tell you a few examples of the things that were asked of me when I went to the IRB, such as, why are you getting pregnancy tests in every single female that you're recruiting? Such as, for a palliative care study, are you telling me that you talk to people after their loved one has died? Can you actually do that? Or, for one of our pre-hospital critical care studies, being invited to be asked, do you actually allow paramedics to intubate patients in the field? Is that a thing? Yeah, so these are the questions that were asked of us when we went to the IRB. And, of course, it's really stunning that our peers in our own institution wouldn't actually understand what happened in the emergency department or even in the field. But this is what happens, right? And this is a lot of the reasons why we actually meet a ton of challenges at our local institutions when trying to conduct work in the emergency department. Quite frankly, they didn't trust me or anybody else in the emergency department to conduct research in the department because they just thought it was a dangerous ask. How could you possibly recruit a patient in the emergency department into a clinical trial? That's not plausible. Well, the first thing that we did is we made sure that we had an annual review with the IRB. And the annual review was a presentation of what emergency medicine is. And so we would do things such as presenting the research that we'd done in the past year, but perhaps make sure that they understood how engaged we were in a lot of the sepsis reviews that were going on. Make sure that they knew that we were part of establishing the stroke center and the advanced heart care center and the trauma center. And so they started to understand over time the importance of emergency medicine and how we interface with all of these different areas around the institution. I met with the IRB chair personally quarterly and made sure that we had a personal relationship such that if there was an issue, he can reach out to me personally. And when I got called to the IRB, I showed up with my posse. It wasn't just me. I brought my regulatory coordinator, I brought my grant specialist, I brought my research coordinator, I brought my research associates, and I needed them to see explicitly that we had a team and that when we said that we were going to do something, we have the resources to do it. So it was a way for them to understand that we weren't just saying that we were going to do these things. I have the people to do it. I have the team to do it. And that posse was very impressive, and oftentimes all of our projects got accepted or approved upon presenting to the full board. The other piece here is making sure that you're looking at your clinical partners. And this is important because your clinical partners can often are your greatest opportunity, but also your greatest threat, right? And so, if I'm going to be doing my research in acute respiratory distress, I have to know that there are pulmonologists upstairs that might also be doing work in acute respiratory distress that may be very threatened by the idea that I'm recruiting patients in the emergency department and conducting an interventional trial in this patient population. So, what do? I reach out to those individuals in advance, make sure that they're not interested in the protocol, maybe they want to collaborate, and then I extend resources from the emergency department to them. And let me tell you, all the years that I was there, despite other people being interested in the areas that I was interested in, ARDS, sepsis, resuscitation, I've never had any pushback, just because we went to them first and we said, are you interested in participating? But had I not done that, you can just imagine with the sizes of our departments of medicine and surgery, how they can easily unravel work that you're getting done in your institution. Nursing. I think this is, pretty obvious to most folks. You really need to make sure that you're engaging your nursing. Even in your academic medical centers, a lot of your nurses are very intimidated by the thought that they might have a patient that is on a research trial. So it's really important to engage them in your research personally, not just send your coordinator, personally sit down with your nurses, explain to them what's going on, explain the research methodology, and engage them. And once they've recruited a patient and done really well with your patient, go back and celebrate the fact that there's been a good outcome, or celebrate the recruitment or the enrollment, and tell them that they did a great job. And what happens after that is they actually become part of the team, and they're engaged for the next, and they're not only engaged for this study, but the next study that comes along, they'll be ready to participate in. And of course, funding, right? The bottom line is that if there's no funding or there's no resources, unfortunately, you can't conduct research. So where do you get this funding from? So of course, you go to your chair. I'm a chair now, so I'm going to also encourage you all to make sure you're looking at other places besides your chair for money. But I did go to my chair first. I had some funds, but very few funds. And then, of course, I had mentioned before that I'd gone to the CTSA. But I'll tell you that industry trials actually played a huge role in us being able to build an infrastructure in our department. The first story I'll tell you is about this study with ACE-induced angioedema. The manufacturers of the drug that wanted to perform an interventional trial on these angioedema patients had actually been approaching immunologists, rheumatologists, for several months, and they couldn't figure out why they couldn't get people to do the study, and those folks who had enrolled had not been able to, those folks that had been engaged had not been able to enroll any patients. Well, the rheumatologists in our institution actually sent the study to our department, and we got to talk to the sponsors. And in talking to the sponsors, we said, well, of course you're not going to be able to enroll any patients. They don't go to clinic. They show up here in the emergency department. And so at that point, they actually restructured their study and started to engage other emergency departments around the country in order to conduct this study. And we did really well. So well that we were able to generate a lot of funding that we were able to put in a pool that could be used for the department and build that infrastructure that I was talking about in terms of getting coordinators and research associates. And it also gave us a really great reputation in the field because there are organizations that help to facilitate the research for most of these industry trials, and they talk to each other. And they say, you know what? You need to go to this place because they're really good at recruiting and they actually meet all their milestones. It won't be a loss of your investment. And this allowed us to actually negotiate very aggressively to make sure we had all the resources that we needed in order to conduct our trials. So we had a number of sponsors and collaborators within just 3 years of starting to work with industry trials. So the advantages of this was we actually got to maintain the skill set of our research staff by engaging in these trials when we didn't have other when our grants had not yet been funded. We were able to build an infrastructure so that we could apply for those federal grants, right? Because without the infrastructure, you can't get those grants from the federal government. we were able to provide experience to those unfunded junior investigators that basically had never had any experience before. And we also were able to build that margin, right? That margin that allowed us to support unfunded scholarship and research, support clinical buy-down for the academic time of researchers, and purchase any equipment. So we were able to build an entire lab with a -80 freezer, centrifuge, and computers. So my area of interest has always been in acute respiratory distress. And while over the past 40 years, we have identified what the epidemiology of ARDS is and actually know a lot about the physiology in terms of the inflammatory cascade that causes damage, and actually just physical damage through ventilators to the alveolar epithelial cells, after about 20 years of the ARDS network being alive and probably about $1 billion worth of investment in research, we really didn't find any pharmacological interventions to help to cease the progression of ARDS or to help to reverse ARDS or improve the outcomes from ARDS. And the only intervention that we were able to find over time was the fact that low tidal volumes on ventilators helped to improve outcomes. So so we wanted to be part of the solution. So as part of this, Dr. Ho, who's here, and I, and a couple of other emergency physicians joined the U.S. Critical Illness and Injury Trials Group. And this was a great group. This was a thematic group out of the NIH where physician scientists that were interested in critical care and trauma would come together and devise a research agenda and some clinical trials. And so one of the first studies was an observational study looking at patients from the emergency department to the floor in ICU that had developed ARDS in order to create a prediction scoring methodology. This initial study allowed for eventually a funded grant that allowed us to perform the first prospective RCT for the prevention of ARDS among emergency department patients with aspirin. And this particular study would be the first to demonstrate that intensivists and emergency physicians could actually work together in order to identify a solution to a very, very terrible disease. This was a negative study, but it was the first of many. And this is what happened after several years. After several years, those first initial studies led up to the opportunity for us to create the PEDAL network. That was the framework for creating a network that allowed for emergency physicians and intensivists to work together in research trials. And out of that network, you can see that there have been several studies, including the most recent one, Clover's, that were published that really help us to understand how best to take care of our patients in the emergency department and potentially how to prevent our patients from having ongoing critical illness beyond the emergency department. And so my relationship with infectious disease extended into influenza, and I joined the Influenza Research Consortium because of my interest in ARDS and the knowledge that influenza actually did cause a lot of ARDS and led to patients being in the ICU. And so in this international consortium, I was asked to join a work group because they had had a study where they had this novel idea where if, God forbid, we had a pandemic, we'd want to be able to have a tool where we could intervene very quickly. And one of the things they identified was convalescent plasma. And they said, why don't we take a look at this and use this in influenza patients and see whether or not it helps to abate the progression towards ARDS and improve outcomes in influenza. So I was invited to this work group, went to Bethesda, and in that room, they were scratching their heads because they had been conducting the study for almost a year, and they'd gotten less than 20 patients in the entire year. And they couldn't figure out what to do because they needed 200. And so I said, have you ever considered the emergency department? So someone said, well, do they infuse blood products in the emergency department? And so that was the beginning of us being engaged in the administration of convalescent plasma to patients with influenza around the country. This became the very first study that actually was published in this space. and helped to at least provide us with knowledge in advance of COVID, before COVID occurred, but also gave me a relationship with a group that was ultimately responsible for managing some of the first trials around COVID therapies. And so I was very engaged initially in some of the trials that were designed around COVID interventions. So, be the solution, participate in clinical trial networks or thematic networks, assume the role of an emergency medicine spokesperson, and when there's an opportunity, present the idea that emergency medicine can be part of the solution, and then of course publish. This is our growth at a glance when I was at the University of Florida, starting out with $18,000 funding, worth of funding. Over 5 years, we were able to generate a multi-million-dollar research mission. In addition to that, we had a growth in our not only our funding, but also our publications. So I'll stop there because I'm pretty sure I'm over time at this point, and see if there's any questions. I'm sorry. Yes.
This was awesome. Thank you so much. Just a little, if you could talk about utilizing the funds from the clinical trials to fund your research. If you could talk a little bit more about how you went about doing that and how that was successful, that'd be great.
So we had to negotiate with the chair. So part of what we knew that we were able to do over time is bring funding into the department, but then the question is that what do you do with those funds, right? So you have to negotiate that. And so if it's not necessarily a priority, you may not necessarily be able to use all of those funds for research. But in our case, because this was such a priority for our chairman, we were able to put the pool aside and use the margins from our former research for seed funding, to protect faculty time, and ultimately to, again, purchase equipment. So that's really the way it was done. At our institution, we also had an opportunity to get some IDC return from the university. So at the end of the year, after we've completed our work, the university would actually return a portion of those indirects back to the department and also back to the PI. And these are things that can be negotiated with your institution as well. That we don't, as emergency physicians, we often don't recognize that that's something that is negotiable at the university level.
Thank you, Dr. Elie. Thank you very much.
And we will have time for more questions at the end. I would like to now introduce our next speaker, which is Dr. Aufderheide. He is a professor of emergency medicine and associate chair of research affairs at the Medical College of Wisconsin. He is also the director of the NIH-funded Resuscitation Research Center. Because I want to give him all of his time, I'm not going to go through all the accolades, but I do want to say a few things, that he's been continuously funded by the NIH for over 30 years. And he has really pioneered the way we approach emergency care research and set up research infrastructure. He has served on numerous NIH grant review committees and other federal agency commissions. And in 2009, he was elected to the National Academy of Medicine, recognized for his significant contributions to the field of medicine and public health. Dr. Aufderheide is going to be speaking on ECMO facilitated resuscitation. Thank you.
Well, thank you, Paul, for the wonderful opportunity to be here today, and thank you for your support of our Siren Clinical Trials Network and all that you do. Like any good researcher, I have a lot of data and not much time, so I'm going to just jump in. Presenter disclosure information is shown in this slide. So there are over 400,000 out-of-hospital cardiac arrests each year in the United States, and 93% of them die. That's over 372,000 deaths per year. In the US, it is the third leading cause of death. For decades, the survival rates have remained the same, 7% overall for all cardiac arrests. We need to do something different. It's been my privilege to collaborate and work closely with an interventional cardiologist at the University of Minnesota, Dr. Dimitris Yiannopoulos, for over 25 years. It was his vision to place refractory VF out-of-hospital cardiac arrest patients on ECMO. And it was a privilege to be an integral member of this research team to develop and implement this program, which is the only program in the United States community-wide with the highest survival rate in the world. So I'm going to take the opportunity to talk about how we implemented this program, our first observational case series, the discovery of the cause of refractory VF cardiac arrest, why this patient population just never responds to anything we do versus those that do, our first randomized clinical trial, some insights we've had as a result of this research, particularly and including a new understanding of the process of death and what that means for our field. So it took about 10 years for us to collectively develop the program, ECMO facilitated program in Minneapolis-St. Paul, essentially restructuring the entire healthcare system's response from living room to hospital discharge. And in 2015, we formally implemented the program called the Minnesota Resuscitation Consortium ECMO Facilitated Resuscitation Program. There were some key components that we included. Early EMS mobilization of VF patients only after 3 failed shocks, a very simplified communication to the ECMO team with a single call, a small core of cannulators, only 3, and that provides a high volume per cannulator, consistent performance, and very low minimized frequency of complications. Especially the ICU care, which is an important component of this program, and no physician-directed withdrawal of life-sustaining therapy ever. All patients are considered eligible for any and all treatments, including major surgery, until such time as they themselves declare themselves definitively dead, such as brain death criteria, or the family independently requests withdrawal of life-sustaining therapy, which they never do unless the physician recommends it. Entry criteria is straightforward, age 18 to 75. VF patients only after 3 failed shocks. They have to have a body habitus that fits active compression, decompression CPR plus the impedance threshold device, the highest flow possible during CPR, which we developed in 2015, and a transport time of less than 30 minutes. These are not nursing home patients. They are not DNR patients, no terminal illness, and no PEA and no asystole patients. So in 2015, we took a look at a first quick look at a small pilot trial of first 18 patients and saw there was a signal. This program was feasible. It was working well. We had a high functionally favorable survival rate of 50% and no significant ECMO-related complications. Small studies, of course, are usually never where you end up, but it looked like there was a signal and we continued. After a year, we had 72 patients, and we took a look at a larger case series at that time. These patients had a very high incidence of coronary artery disease, 84%, with severe acute on chronic occlusion of their coronary arteries. And they were young. Average age was 58, and stunningly, 91% never knew they had coronary artery disease, and the first clinical symptom of coronary artery disease was death. Our overall survival rate was 45%, which was 3 times higher than a retrospective control, and we were very encouraged. With that, Since case series has selection bias, we designed and got funding for the ARREST trial. This was the first prospective randomized clinical trial randomizing patients to ECMO-facilitated resuscitation versus standard ACLS treatment. It was a phase 2 single-center intention to treat safety and efficacy study. The inclusion criteria was the same. This trial was blinded both to EMS as well as outcome assessment. And the effect size of what we were doing with ECMO-facilitated resuscitation was so large that NHLBI, based on a unanimous recommendation of the DSMB, terminated the study for efficacy after the first 30 patients because it exceeded the pre-specified stopping criteria. Overall survival rate was 43% for ECMO versus 7% for standard care. There was one patient who survived a hospital discharge with standard care who was neurologically devastated and died 2 months later. All of the patients with ECMO-facilitated resuscitation at 6 months were normal neurologic outcome, except one that was near normal. The cumulative survival difference between our standard care and ECMO-facilitated resuscitation was significant with a p less than 0.0001. And we had the opportunity to publish that in Lancet. So, based on that experience, what have we learned? Well, we've learned that these patients are treatable and they are salvageable. They're young. The average age is 58, and 14% are less than 40 years old. They're in the prime of their lives with every reasonable expectation of a long, continued quality and duration of life. This approach with ECMO-facilitated resuscitation provides 20 to 40 times higher likelihood of normal survival than our current standard of care. We are not creating vegetables. Survival with poor neurologic outcome with ECMO is 3%, which is half what our current standard of care is. And we have discovered the cause. The cause is severe coronary artery disease with near total occlusion of all blood flow to the heart. As such, if we continue to treat this patient population with our current standard of care, we can't expect to significantly improve survival or outcome. This is a fundamental principle of medicine. Okay? You don't treat cancer with antibiotics because it's not the cause. Same thing with this patient population. This is a graph of the duration of CPR shown on the horizontal curve out to over an hour and a half of CPR on the horizontal axis and functionally favorable survival on the vertical axis, with standard of care shown in orange versus our experience with ECMO shown in blue. What you can see is that with standard CPR, no one lives after about 40 minutes of CPR. In contradistinction, with ECMO-facilitated resuscitation, there seems to be a survival barrier around 60 minutes, but note that we have a consistent 18 to 20% normal survival rate out to 1.5 hours of CPR. I want to tell you a little brief story that really changed my perspective with ECMO. I was rounding early on with our first ECMO patients with Dr. Yiannopoulos, walked into a room, and there was a patient who had been in the ICU for a week, no signs of life whatsoever. There were machines everywhere keeping this person alive. And there were so many machines I could hardly see the human being at the bottom of the bed. And I looked at that and I said to myself, why are we doing this? All is lost. It's been a week. Why don't we shut these machines off and let this poor human being die in peace? Well, the next day, we walked into the same room, and to my astonishment, they were sitting up in bed, looking around the room, and as soon as we walked in, they looked at us, he looked at us, and he started pointing at his endotracheal tube. Take this out. So we extubated him. He coughed up some phlegm, said a 4-letter word, which I will not repeat, and his wife, who was standing by the bedside, broke down and wept for joy because she realized that her husband was back. And in that same moment, first, I felt ashamed of what I had thought the day before. And then I felt lucky not to have verbalized what I thought. And then I suddenly realized that everything I had ever been taught about the process of death was wrong. So, what is death? Well, death is not an event, it's a process. And any process can be successfully interrupted and reversed. It's like an acute myocardial infarction that we treat every day. An acute MI is a process, and that process is 6 hours long, and our job is to intervene before that 6-hour period of time. So, how long is the process of death? Well, I don't know about you, but I was taught 3 to 4 minutes without oxygen and all is lost. Well, is there scientific evidence for that belief system? And is it true? So I did a little homework, and I found this article published in 1940, where investigators occluded all blood flow to cat brains and found permanent pathologic lesions after 3 minutes of occlusion of all blood flow. And I found this article from 1956, before closed chest compression was discovered, when they were still doing open chest CPR, where they stated that patients needed to be resuscitated within 4 minutes in order to have a good outcome. Well, fast forward to 2018 with this article published in Nature from Sestan and colleagues at Yale. These basic scientists went to a pig slaughterhouse with IRB approval. The way the pigs were terminated was decapitation. They took these pig heads back to their research lab. They flushed out the brains and reperfused with a perfusate, a pulsatile perfusate, and through a series of very careful basic science, proved the following: that vascular function was restored and maintained, that cell death stopped, that the nerves and synapses had return of electrochemical function, and that global cerebral metabolism was restored and maintained. They concluded that cell death in the postmortem brain occurs over a much longer window of time than widely thought, and fundamentally proved that post-mortem brain cells retain the capacity for full restoration, and that global cerebral metabolism can be restored multiple hours after death. Well, what are the clinical implications for the practice of emergency medicine? We declare people dead 2 ways: either brain dead or a clinical declaration of death. Brain death is only 2% of the time, 98% of the time. It's a clinical declaration of death, and I would argue for us, it's 100% of the time that we declare patients clinically dead. What is this declaration? Well, it's essentially a functional definition. So there are no signs of life, We've exhausted all known effective interventions and have nothing further to offer our patient. Well, this is a reasonable thing to do and a very appropriate thing to do. However, with this new understanding, I have to realize that probably almost every patient I've ever declared dead in my emergency department throughout my entire career was really not dead at all. In fact, we have a new third definition of death now, which is irreversible biological cell death. And irreversible biological cell death occurs at least 4 hours after the clinical declaration of death. This provides us with a window of opportunity for the future to devise effective resuscitation interventions. Our clinical experience with ECMO-facilitated resuscitation supports this new scientific understanding. Our ECMO patients are salvageable much longer than previously recognized. We get functionally favorable survival with an hour and a half of CPR and have as yet had no absolute limit identified. Our current neuro-ICU prognostication practice becomes essentially a self-fulfilling prophecy. Withdraw care, of course the patient dies. It inserts ascertainment bias and undermines confidence in the validity of our current practice. Our ECMO-facilitated patients have first neurologic awakening on average 6 days following admission to the ICU, which is twice as long as currently recommended nationally. Our longest patient first had neurologic awakening 3 weeks later and left the hospital normal. Resuscitation medicine knows little about the process of cerebral awakening following an ischemic insult. With the heart, it's easy. The heart starts to beat. But cerebral recovery is return of electrical activity after an unknown duration of coma. So, in summary, 3 minutes, this 3 minutes without oxygen belief system is no longer supported by scientific evidence. That 80-year-old myth should be aggressively discarded. The process of death and the resilience of the brain to recover from an ischemic insult is much longer than we have generally recognized. And this new evidence extends the window of opportunity for new and more effective resuscitation interventions for the future. There's a critical need to move away from the heart and focus now on the brain to develop more effective neuroprotective strategies. This new science raises important ethical considerations of this new reality that can and will be addressed. Moving forward, we first need to recalibrate our own belief systems. How do I believe? What do I think about this? And then recalibrate the entire healthcare system's approach to cardiac arrest following ischemic insult. This belief system significantly impacts how we care for our patients. Our understanding of the potential salvageability of these patients, the process of death, and especially cerebral awakening is just beginning, and we have a lot to learn. I want to thank the people in this slide. I particularly want to thank Dr. Ian Martin for his support of research in general, and in specific, his support of our NIH-funded resuscitation research center, some of the data of which today would not have been possible without his support. Especially, I want to thank my wife, Ann, whose love and support have sustained me through a long career. Thank you.
Boy, those are two incredible talks. Key takeaways for me that our colleagues in industry have no idea what we do in the emergency department. But if we educate them, they might give us money. Second is like you should go to your chair and get money. and then from Tom, I mean like Frankenpigs. And so it's quite amazing. And all I was struck with the last part of your talk was Monty Python, like I'm not dead yet. And so open it up for questions, please.
Thank you so much. That was kind of crazy. So you had mentioned the inclusion criteria for your study was less than 30 minutes transfer. Is that including downtime, I'm guessing, of the patient before CPR was initiated?
No, because we only do VF patients, within broad parameters, they still have to be in VF, an initial presenting rhythm of VF, and that keeps the patients generally in a similar downtime within broad parameters. The transport time is paramedic transport time, just simple. Can they get to the cath lab within 30 minutes?
Thanks.
We do have now a lot of apps and electronic ways to assess that, and paramedics use that on their cell phones all the time.
Great. Both talks fantastic. My question's for Carmel. Nick Moore from Iowa. Thank you for sharing with us your kind of story about developing emergency medicine research clinical trials. I'm interested in your views on the pathway or the pipeline of emergency medicine researchers, because I think that this is something that we've thought about for a long time. Part of this is, can we do research in emergency departments? But part of this is who's doing research in emergency departments, and do we have people who are likely to be future PIs of independently funded large clinical trials? And both of you have kind of demonstrated the ability to do that. Maybe you could comment just a little bit on the pipeline issues and how we might do that better.
Good to see you, Dr. Moore. And this is a great question. In fact, Dr. Aufderheide and I were talking about this right outside before the talk. So my opinion really is that the pipeline starts well in advance of residency. And if there's an opportunity for us to reach out to undergraduates or medical students, that we can create that pipeline and we can develop a group of young investigators or just young learners that want to aspire to do the work in our space that is so important, right? So I actually, my scientific career actually started when I was an undergraduate. So when I was at Columbia, I worked in a lab for several years, and that inspired me to do research. And quite frankly, I think that we need to be thinking about that more often, even in our environments. I think there is, yes, and there is, so somebody from your group actually has brought a high school student to this meeting and presented today, right, just about a couple of hours ago. And there, there are a lot of very, very intelligent young learners out there that want to work in our space, and I would say start recruiting them early. And start inspiring them to do work in our space, and start teaching them research design and methodology and stats and all of the tools, the basic research skills that are needed in order for them to be future scientists. Now, we understand that they're not all going to be scientists, but there might be a few of them that might be inspired enough to do this work. And so I think that the pipeline really starts as early as you can possibly think, and even high school. I hadn't even thought about that until we learned that there was a high school student presenting here today. But quite frankly, I think that the possibilities are out there, and we just have to be willing to reach out to those learners in our space.
So I couldn't agree more. Earlier is better. I think in general, scholarship of our field is important to foster and support. I want to give a shout out for K Awards. So for those selected individuals who wish to commit to a continuously NIH-funded career, the process to successfully achieve that is no better than a K award process. Jane Scott has started that process in emergency medicine. She's done an absolute phenomenal job, and it is a wonderful opportunity for those rare individuals who wish to have NIH-funded research to consider a K award.
Hi, Jeremy Brown from NIH. So first of all, two terrific talks. I'm going to address my remarks to Tom. There is a movement now in the whole field of neuroprognostication, of which I was completely naive, much in the same way that you were perhaps naive of ECMO. And this thing is a real, I mean, the data is very, very compelling, and so compelling that I told my kids that I'm still DNR, but they have to give me a week to declare myself before they pull the plug. So I want to ask you a couple of questions, and I really do applaud you, Tom, for your enthusiasm and your humility, and it's something that alone we should all learn from. But number one, the Yale paper on the decapitated pigs, they gave them general anesthetic. It's very unclear what the return of an electrical force was in the meaning of a decapitated pig brain that's had no circulation for a while. And I just wanted you to comment on that. It's an intriguing hypothesis, but we really have to go a long way from saying we can now resuscitate brains that have been down for hours. And the other thing I just wanted to ask was a clarification. So you said that the vast majority of these cases were coronary artery disease. So I'm on ECMO. You've resuscitated me. I'm on ECMO. What happens next? You take me to the OR, you do a bypass, or you do a stent? What do you do? And then how do you then, what intervention do you do to get me off of ECMO? And thank you again.
Okay, so Jeremy, I'll answer it in reverse here. So I probably should have been much more clear about our process for ECMO facilitated resuscitation. ECMO does nothing to improve survival, absolutely nothing. It is used as a bridge to the cath lab, where we do coronary angiography. 84% of the time, we see literally no flow to the heart. Both the right and left coronaries are completely occluded from acute on chronic occlusion. Once you open up flow to the heart, 50% of the time, the heart starts to independently beat. You don't even have to defibrillate. You just return flow, and the heart starts to beat again. So that is why we use ECMO, not because ECMO in itself improves survival, but we treat the cause, which is complete coronary occlusion. So thank you for that question, Jeremy. Yes, perhaps I was being a little bit dramatic today, but the SESTAN paper, as well as ischemia reperfusion injury data from labs all over the country for the past 20 years, support the contention that cells are really not dead, and that mostly they die on sudden reperfusion, sudden oxygenation, and reversal of the acid-base status to normal quickly. SESTAN has taken this a step further and now successfully resuscitated entire pigs 1 hour post-mortem. So there's continued support for what he showed in his original paper. They were very concerned about restoring consciousness. And so they gave anesthetics and other drugs to assure in their final paper that they could contend that they did not restore these brains to consciousness. And so that limits somewhat their findings. However, I think that taken in total, what we're seeing with ischemia reperfusion, their first paper, as well as now resuscitation of whole pigs, with this process, I'd like to do this process in the first human, if we could. You never know. The ultimate end game is what is the optimal way to reperfuse people back to life. And I think Sestan has showed us at least the direction we need to head.
I'm sorry, one more question. So you said it's 400,000 deaths out of the hospital and 372,000 die, so 7% survival. But those are all comers. So I was wondering how much you making a little bit tighter criteria. So if you're a nursing home, if you're more than 75, if you're DNR, if you're not systole, how much you just changing criteria, how much you essentially increase survival rate?
That's a really good question. Our overall, when you look at survival rate, well, I'll tell you what, it's from 0 to 43% is the simple answer, okay? And the reason is that all our current survivors, if you take all VF patients, 1/3 respond to what we do, and 100% of our survivors are in that 1/3. Are you with me? We are addressing the other 66% that never respond to anything we treat our patients with advanced cardiac life support. So the answer to your question is 100% of the patients who live would not have lived otherwise. Are you with me?
So the question is, just trying, if we narrow indication and we pick up the patients who have the highest chances to survive,
Yes.
just narrowing of indications for this process will increase survival rate.
In other words, you pre-excluded nursing home patients, for example.
Sure.
So you're cooking the books a little bit, I think.
Well, no, we are not cooking the books. Any survivor of cardiac arrest comes from the 1/3 of VF patients that respond, right? I mean, if you've got a nursing home patient who responded, they by definition are responders, okay? We are taking patients who never respond and get a 43% survival rate.
Thank you. Last question.
John Rubin, Medical College of Wisconsin. I have a question for Tom, but I promise I'm not a plant. So I'm curious, what are your thoughts about how this work translates into broader clinical practice? And obviously, it's extremely resource intensive, labor intensive, from the field all the way through to ICU care. But I mean, the results are incredible. So how do we balance that?
Right. This is a huge investment, financially as well as medically, of medical resources. There's no question. Maybe I'll just be a little bit of a tease here in that we believe we have a different approach that most communities could easily adopt and implement with success. And we are writing that grant currently. And perhaps I'll have the opportunity to come back and show you what our results are at a future SAEM. But it's difficult to do, and most communities find the barriers too high to quickly implement today. We need a faster, more efficient, easier approach to make it more widely generalizable.